Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast, I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. Hey, it's my great pleasure to welcome Anju Jaggi to Glenohumeral Gurus podcast. Anju, welcome. So nice to catch up with you this morning, your evening. Lovely to have you on.
Thank you so much. I've been really excited about this, so this is great.
Hey, so can you tell clinicians a little bit about your career, how it is that you got started into this, how this shoulder thing started, and what it is that you do now? Can you share with us?
Yeah, absolutely. So for those of you that don't me on that other side of the world, oh my God, you feel so far away.
Yeah.
Um, yeah, so I basically work from a very specialist hospital in Northwest London. It's called the Royal National Orthopaedic Hospital, and I hate to say this, but I've been there for about 27 years, so you can kind of guess how old I am. I went there kind of probably about 3 or 4 years after I qualified. It was a well-known hospital and remains a well-known hospital because we do very specialist orthopedics. And at that time, they did have shoulder and elbow as a subspeciality, which was actually really rare, Margie, because if you think about 30 odd years ago, most orthopods were still quite generalists.
Yes.
But I had the privilege of working with a surgeon called Ian Bailey, which we'll probably come on to talk about when we talk about the Stanmore classification.
Yes.
So early on at Stanmore, shoulders and elbows started to become a subspeciality. So I was in a unique position that I went there as a junior physio, and you could literally just do upper limb work,
Yeah. Wow.
which was obviously hugely unique.
Yes.
And kind of, I suppose that's kind of where it started. I remember actually initially thinking, oh, if I do this, and I just do this, I'm at real risk of de-skilling in lots of other areas. And, I'm only at the start of my career. Do I want to specialize this early? I mean, the irony, really. But yeah, very fortunate, ended up on the shoulder and elbow unit. And it'll probably come through the theme because you'll see that my research and everything's been heavily influenced by
Yeah.
mentors, one of
Yeah.
which was Ian Bailey. So I landed onto the shoulder unit. I developed a passion, but I was given amazing mentorship. Um, I remember seeing really wobbly shoulders that were just popping in and out of socket,
Yeah.
literally crying, thinking, what the hell do I do with these patients? And they were really
Yeah.
challenging. And actually in Bailey, I remember one day just peered down from his glasses and just said, grow to love them, Anju. And 30 years on, I sure do. So my
What
career,
great advice.
yeah. But I've also been incredibly lucky that I've managed to stay at the Royal National Orthopaedic for that whole career journey. And I started off, I don't know what the grading's like, how it works in New Zealand, but started off with what's called a band six. So you're usually a senior physio who's probably had about 4 or 5 years experience. And then I kind of sequentially worked up.
Yes.
Other surgeons came on board. It became quite apparent that the work we were doing at Stanmore was relatively unique, particularly with atraumatic instability.
Yeah.
I got encouraged to sort of start clinics and see these patients in my own right, but also lecture and teach. And the long and short of it then is my career journey has gone to now where I am, which is a consultant.
Yes.
Um, so I get patients referred to me directly from all over the country for specialist opinion. Um, and then I was lucky to have some what we call SPA sessions to do a bit of academic work. Um, but now, more recently, because you know me, Margie, I get a bit bored if I don't. So, not that I'm bored of shoulders, but I really enjoyed my academic work. But I became really passionate about trying to get the rest of our allied health professionals much more academically focused and
Mm-hmm.
kind of get standards up. So I've stepped into what's called a clinical director role, which basically pulls me more into management leadership, but
Yeah.
I hopefully have a bit more strategic. So I'm trying to kind of think, actually, I had such good opportunities and I really developed a clinical academic career. I'd like to now do that for others as they're starting to come through, so that
Yeah, that's a
therapy becomes evidence-based, really.
yeah, it's a fantastic contribution, isn't it, for both just sharing your experience and then, helping others follow after you. Hey,
So just to say, I do 3 days clinical.
yes,
So I do a consultant clinic a couple of times a week, which we'll probably come on to talk about that.
yeah,
It is quite niche. It's very much complex pain and instability.
yes,
I still also see people for rehab. So I do some physiotherapy treatments as well. And
yes,
then a couple of days of my week is kind of non-clinical, which will be trying to develop research projects, but provide leadership, really. So that's
yes,
kind of where I'm at the moment.
yes. And how do you find the balance of all those things? It's nice still to be clinically. 'Cause I guess I find I'm not doing so much rehab anymore, just lots of consultancy,
I know.
which I kind of miss,
Um,
but it's,
yeah, really good question. I That's why I'm really glad I still do therapy. So I will still see
yeah,
people
yeah,
um, for that, because I think if I just did my consultant clinic, particularly when we come on to talk about the patients that I particularly see,
yes,
um, how do I put it? You don't get those quick wins. You know you're
no,
making a difference, but you don't feel it, and you don't often sense it or hear it until some way down the line or your colleagues tell you. So I think there is a risk of burnout
mm,
if you
mm,
don't.
yeah.
Um, so I think the clinical's just about balanced. Um,
Yeah,
and I
right.
think the
Nice.
other side, the leadership side's been, I'm really up for a challenge. What I think becomes increasingly difficult is that as you enter that world, you have aspirations and you have visions, but sadly the politics um, does does get in the way, and it does influence, and you may not have control over what you want to do. But
Yeah.
it it's really good developmental stuff. I would
Yeah.
also say that um, by being in my role and doing the clinical work, I think gives you credibility.
Yeah. Yeah. I'm not sure
Um,
you need much more credibility, to be honest, Andrew, but anyway. Hey, so I had some specific questions I wanted to ask you. Firstly, around the Stanmore Triangle as a method of classifying instability. It's not something that I use. I would probably go to a Fed system much more often to help me in that space. Can you broadly outline it? And then I've got some specific questions. So you could tell people about the Stanmore Triangle?
yeah. So the Stanmore Triangle literally has kind of three polar points as a triangle.
Mm-hmm.
So and it evolved from the Tubbs and Ambry, infamous Thomas
Yeah.
and Matson classification. So without overcomplicating things, essentially it comes from that traumatic versus atraumatic instability.
Yes.
Um, but what Ian Bailey started to talk about was that there also possibly is a third group. And the essence of his triangle was also to say is that instability never quite just sits into one polar group. There's a
Yeah.
continuum,
Yeah.
and things can evolve.
Yeah.
And don't I think we have to be very objective here. There are lots of classification systems, as you've alluded to, like FEDS and others. So in no way are we saying the Stanmore Triangle is it and it's superior,
Yes.
but it's another classification system. The advantages, however, though, it does allow you to recognize that continuum and how
Yeah.
patients can move around. So if we keep it simple, at the top of the triangle, the top point is your tub. So that'll be your
Yes.
traumatic, unidirectional, and car surgery. Okay.
Yeah.
So when we think about FEDS, when you sort of asked me that question, or when I was looking at that question, FEDS is very much kind of a description of the instability. So, its direction, its frequency, its etiology. Whereas what the Stanmore classification does is it describes more how your management strategy should be. Does
Yeah.
that
Okay.
make sense? Okay. So, for instance, if you're a traumatic unidirectional, you've had a structural lesion, then the basis of probably treatment is structural pathology. If it's broken, it kind of may need fixing. Okay.
Yeah.
Now we can have another debate about whether we should operate.
Couldn't we?
Got enough time. But essentially, we're thinking then is the more the trauma, the more the damage, perhaps we may need to think of surgical options. As you then come down the right-hand side of the axis, you come to the second point of the triangle, which is what we call your polar 2.
Yeah.
And that's evolved from your Ambry group. Yeah.
Yeah.
Traumatic. Personally, for me, multi-directional in that context means multi-directional laxity, not necessarily instability. So these patients might be very lax and hypermobile, but their shoulders generally will tend to be symptomatic in one or two directions. So it's really that they will describe a feeling of antro-inferior or postero-inferior. So what I would say is more bi-directional. And with that group, partly because based on Thomas and Matson's, Rockwood's paper, we know that rehab strengthen them up. So essentially, you could say is the top group is you're pushed out with force. Type 2 group is you're not held in well enough because the balance of strength isn't good enough. And then as you come down the bottom along that bottom axis to the third group, that's polar 3. They're very rare, but these essentially are patients who are similar to type 2. It's atraumatic, they're multidirectionally lax, but they also tend to present with that rare phenomenon of a bit of MDI. Sometimes it might be some voluntary instability. They can party trick or initiate the shoulders to displace. And they also then, when you watch them move with abnormal recruitment strategies, you'll see winging of shoulder blades, you'll see muscles activate. So in a clinical basis, there's clearly evident muscular recruitment strategy issues. So those are the 3 polar types. So you kind of almost could say is that bottom axis is almost being pulled out, but maybe pulled out by muscle control.
And so people can move along between those planes, you think?
So you could have let's take an example. So for you, like Margie, you could be treating a rugby player. Let's just say for devil's advocate, they have a Bankart lesion. You go in, you do a stabilization, but for whatever reason they come back and they're saying, look, I've got recurring pain or I'm feeling my shoulder slipping. You do an MR arthrogram, repair looks fine, everything looks in place. But now maybe the patient is compensating for stability using, let's say, P major rather than subscap. So what you could argue now is you've gone from a 1 to a 3.
Okay.
Okay.
Because what I haven't understood then is how to classify people I would call, say, I saw a lady yesterday, she got rotator cuff related pain secondary to a tight posterior capsule. She's positive with her sublux, the person I'm talking about. Do they fit? I've never put them on a triangle. Do you know?
That's really interesting. Yeah. So those are kind of, I suppose we often talk about the younger population who come with what appears to be impingement type shoulder symptoms. And I know that our colleagues in Australia, Tanya Pizzari, and I kind of agree that I think that younger population, that's probably an element of instability secondary to cuff insufficiency. You could probably get them into a type 2 category.
Okay, because it's and I guess broadly speaking, you're saying the type 2s need the muscle strengthening for more stability. Therefore, they don't necessarily present with a subluxation, but more sort of that what I call micro instability, where you have that cuff instability. Okay.
But there's no structural pathology. Cuff is not torn, there's no labral, there's no So I would almost say they, for me, could almost sit as a type 2. You could almost argue that actually quite a lot of rotator cuff related shoulder pain is almost type 2 instability.
Wow, those are the ones that I see in my consultancy role that are cuff related pain that doesn't get better, so then when you look and you identify that instability component, then they do well. Those are the ones that seem to get missed. It's because people don't look, maybe.
To keep it even simpler, here's your triangle. What we would say is the more the trauma,
Yes.
The further up that end, and you might need to think about imaging, and you might need to think about surgical intervention. The
Yes.
lesser the trauma
Okay.
and the more the muscular deficit,
Yes.
vary and think non-surgical.
Yes. Yes. Okay, that's helpful because I've seen those triangles with those, and I haven't really understood that. So it's really nice to talk that through with you. I've also seen some work, or I've seen you present work on using a biopsychosocial model, and as you we share an interest in the psychological impact of shoulder pain, shoulder instability. Now's probably a good time to branch into that, eh? What? Because the consultancy work that you do, often these people have had pain for a long time. Tell us about that. Tell us what your thoughts on that.
Yeah, and I think it comes back to the point. So when we think of all the classification systems that are out there, when I often start the lectures, they've always come from a biomedical slant.
Mm-hmm.
So if we think of our orthopedic world and the orthopedic world that I grew up in, we were really good and very strong at the biomedical model. So
Yeah.
we were very much, if something's not working, it's either broken and it needs fixing, or even, dare I say it, we even respected muscular motor strategy as a biomechanical problem. There's some kind of
Yes.
imbalance, or
Yes.
there's a lack of proprioception. Okay, that's
Yes.
how I think where we need to evolve, and that's where I would say that there are perhaps limitations of some of the systems, even the Stanmore, is that what we
Mm.
don't recognise is that biopsychosocial. Now, what you and
Yes.
I know, and what we see, and we're going to come on to talk about the take-home messages, but I now, when patients come into me, they're not getting better. It's almost like the biomedical's been exhausted. You've had every
Yes.
imaging under the sun. You've had the surgery to fix what may have been broken. You've had the good physiotherapy. But actually, we know that when you're under stress, you're anxious, you're fearful,
Yes.
you're avoidant, and we'll come on to talk about functional neurological disorder. The groups I'm now seeing with, deep emotive trauma, not
Yeah.
from a perspective, but from psychological perspectives. The body keeps the score,
Yeah. Yeah.
and so therefore, what I think we need to now understand, and we're evolving into, but perhaps for the first 25 years of my career, I didn't recognize the movements of the brain, and muscle movement strategy has got so many things driving it.
Yeah, it's incredibly powerful, isn't it? And I think the work is still really evolving in that space. And my other thing that I would think of, think of the patients that I've seen, it's incredibly individual. So, I want to talk to you about your randomized controlled trial, but there's no way you could do a randomized controlled trial on these. There's just some things, this is that, this, like this, it's so many different parts that is never the same for the next individual like that. Is that your experience?
Yeah, totally. And I think now that's why when I'm framing patients, and we've just published a paper in the Shoulder and Elbow on clinical assessment, so a scoping review looking at clinical assessment for atraumatic shoulder instability.
Yes,
And
yes,
just
I've
to
seen
kind of
that.
give you the conclusion of that was that,
Yes,
not surprisingly, most of the literature is all focused mainly on trauma.
yes,
There is some on ASI, but again, we've done it from a biomedical model. So when you look at the literature, most of the way to assess it is, well, image it,
yes,
do MRIs, do scans, do instability testing. And even though atraumatic instability, we know that the management has to be non-surgical. When you look at how we clinically assess it, it's all very
yeah,
mechanically biased.
yes, yes,
Our scoping review was trying to see was, well, is anyone talking about the fact that actually when you've got ASI, perhaps our focus should be more on looking at muscle strategy, looking at
mm,
movement control,
mm,
looking at what
mm,
factors drive that. Um,
yeah,
so you can see we've got a long way to go because the way we still clinically assess it is very biomedically based.
yeah. And do you have any tips then for clinicians, just thinking about that assessment review? How do you think clinicians should be assessing atraumatic instability? What's important for them?
Well, I would say the subjective history is really important. So I think a
Yeah,
bit of an understanding on what makes it come out, how easily does it come out, how do you deal with it when it does sublux, the
yeah,
levels of pain, but then also understanding of what do you believe it's going to get better, How do you
Yeah.
feel it's going to get better? Yeah, self-efficacy around that. What do you
Yeah.
understand it to be? And then when it comes into the clinical assessment, you sort of know it's unstable. They're sort of telling you that. You might confirm the direction, but I would almost say it's less about the feds approach. It's less
Yes.
about worrying whether
Yes.
it's back, front, foot, but more than, okay, have you got an imbalance? Is strength the problem that's driving this? Is it
Yes.
a lack of knowing where your shoulder is in space in relation to the rest of you? Is it the
Yeah.
fact you're really hypermobile and you don't know how to recruit in those
Yeah.
extremes?
Yeah.
Or is it
Okay.
actually just because that I've tested you, you're lax, but you're strong. You know where your arm is, but actually this is something else. This is fit. Do you see? So,
Yeah.
um,
Yeah.
and also maybe, and we do have to be careful, but symptom modification tests, which is something that's quite popular over here in the UK,
Yes.
but actually rather than our focus being more on what's the damage and what's the mechanics that are creating this, probably the focus more on is how do we get you to move better to make this feel
Yeah.
better for you and more
Yeah.
safe and less
Yeah.
worried.
Yeah. And do you have any tips for clinicians in that space? Because you've talked about
Yeah,
how do you
yeah.
tell which is which there?
Okay. Quick wins. So with atraumatic instability, I would say that the more complicated group, Margie, usually what we call the MDI group, is because
Mm.
I would say the shoulder blade just doesn't know how to behave itself and it doesn't know what it's doing. So if
Yeah.
you wanted quick tips in the clinic, being able to even know whether they can isolate elevation of the shoulder blade.
Okay. Yeah.
If they're lifting their arm up and the shoulder feels like it's dumping down and feeling
Yes.
like it's plunking out, quick wins for you could be is what happens if I make your shoulder blade stay where it needs to as you lift up. So
Yes.
elevation. The other thing as well is that then if you push against me, so those outward tests, even putting your thumb into their armpit, yeah,
Yes.
because actually what you're doing there then is you're trying to, for a lot of these patients, it's very much around, I think, trying to get the arm muscles to work with the shoulder blade muscles.
Yeah.
Does that?
Yeah. Yeah.
Yeah.
And
So
cueing that balance, that's
and
what
cueing that back. And the other things like step and reaching. When we talk about kinetic chain, I
yeah.
think I think there's lots of things going on there. We
Yeah.
know now with our more complex group that maybe when you say step and reach forwards or go to get that point,
Yes.
that you're trying to make the scapula go up, or is it actually you've just distracted the patient? So now their brain is not even thinking about, oh, I
Yeah.
had to lift the shoulder. Actually, I've had to think about taking my leg. And so we're now even thinking that functional related tasks can actually be really helpful here.
Yeah.
Taking
With
your
that, it
brain
gives you that
into
external cueing, doesn't it?
exactly. Yeah.
Yeah, those are fantastic tips. Fantastic tips. The thing that I wanted to talk to you about that we talked about in Rome is this wonderful paper you've done with Karen too. I had her recently on the podcast. So this around it's a randomized clinical trial, isn't it? Looking at surgery
Yeah.
versus. Well, tell us about it. Tell us about the.
Okay. Well, I'm really proud of this work,
Oh, it's
and
amazing.
I have to acknowledge all my co-authors, which includes several of my orthopedic surgeons at Stanmore, Karen Ginn, and yeah. So yeah, it was a great piece of work. We set out to basically answer a question. At Stanmore, we were sent lots of atraumatic instability. We'd get a whole bunch better with good physiotherapy treatment that we know does work for about
Yeah.
80%. And then we were left with this group. And the literature told us that if they fail physio, then perhaps if you do what was then called a capsular shift, you literally, dare I say it, take the bagginess out of a very capacious capsule, you anchor it up. This could be helpful and further patients improve. There was lots of discussion as well that maybe are you better doing that operation as a starting point because it might help with proprioception and feed forward.
Yeah.
So we basically were doing this operation. We didn't really know whether it worked. And then we came up with the concept as, well, why not actually run a clinical trial and compare that surgery, but compare it against a placebo. Now, as you
Yeah.
know, placebo surgical trials are very challenging to do. But at the time, we were very fortunate that as part of the process to assess whether there was pathology, we did a diagnostic scope, because
Right.
MR arthrograms were kind of evolving, but were still not the gold standard. So we managed to get ethical approval to say, well, look, if we're going to think about operating in these patients anyway, we would always, as a precursor, do an arthroscopy to really see, is there a capacious capsule? Is there a bit of sculling of the labrum? And that's how we managed to get it through ethics.
Right.
The challenge for us is, ASI, although we thought was very common because we just get sent it a lot, it was difficult to recruit. The lessons to be learned around feasibility, and if I'm running another trial, there's lots of things I would have done before setting out. But the long and short of it is, it took us about 8 years to recruit just under 70 patients. We powered up the study using the WOSI. So for those don't know, that's the Western Ontario Shoulder Instability Index. You need to make about a 10-point change to say there's a difference. So when we worked with Rob Herbert, brilliant statistician, he told us we'll need about 140, 70 in each group, to be able to say whether there's a big enough difference between the two. Took 8 painful years with COVID in the middle of it. We got to the 68 patients, and we decided at that stage then to do some interim analysis, which you should do anyway.
Yeah.
And thank goodness that when the stats came back, Rob basically told us that he said, well, you're already kind of getting a pretty clear result. So in a way, ethically, even if you went on to do the full 140, I don't think you're going to get a different answer. Which was actually really relieving, because
you'd still be doing it, Anju.
Yeah. So in terms of its really tight methodology, patients were basically invited to have a scope. The surgeon then in the operating theatre would look inside if they deemed them appropriate. So they had something there that they could tighten. Then half went on to have the operation. The other half, they just didn't do anything and went off for a cup of coffee.
And they were randomized
They were randomized through envelopes that were randomized in Australia. So a computer, the envelope was sealed. They were all posted over to us in the UK. And the sealed envelope was handed to the surgeon in the operating theatre once he had completed the scope. So he couldn't sort of be biased into thinking, well, I'll tighten this one because I think it needs tightening. It was literally, So concealed assignment in terms of allocation. Patients asleep, they're under a GA, so they have no idea. The only people who knew were the operating staff, the theatre staff, and the surgeon. All the patients were followed up exactly the same, so they were all placed in a sling. And given the usual protocol, so as if you'd had a capsular stabilization. So the physios were also blinded. We kept the real operating note in a sealed envelope in the research department. So if we had to know, but nobody else knew.
And what about? Sorry, carry on.
And then we had an independent assessor who then took their baseline measures and did their follow-ups at 6 months, 1 year, and 2 years. So there's a 2-year follow-up, which is a pretty good.
It's fantastic piece of work, and like during COVID, and I just it's difficult. These kind of trials are difficult, aren't they?
Really, if anyone spoke to me, it's a bit like running a marathon year when you go like, I will not do that again. But now that we've done it, if someone's like, oh, do you fancy running a trial?
You'd be like, oh yeah, you'd be up for that.
Tell us
the key findings.
I'm not sure placebo surgery would be the right one, but anyway, so key findings, the big conclusion was that what we found was there was no clinical significant difference between those who'd had the placebo versus the surgery. The time, in fact, at 6 months, the ones who'd had placebo were actually doing slightly better than the ones who'd had the operation. And definitely 2 years, no difference. So the conclusion is that if that operation is helping, it's not because of the anchors and the actual procedure. It's either helping because of placebo. There's a strong belief that they're now confident, or they feel something's been done, or it's because they did physiotherapy following the operation.
Right. And who are these people? I know you and I have talked about, who are the people? They didn't all have a dislocation previously, or tell us who are
they can do. So the way we defined the group is there had to be no what we termed high forced injury to the shoulder. Okay,
Yeah.
so what we
Okay.
call a traumatic incident. So if somebody
Yeah.
said to me, I went to pick a laptop bag in the back of the car and I felt my shoulder dislocate, I brought it back and I put them back in, that's atraumatic to us. Okay,
Yeah. Right.
there's no documented evidence at that, you know, they may have dislocated, but there's no documented evidence. But also, you would not expect a normal person's shoulder to dislocate. So, had to be a minor event. Anything that felt like was high forced injury or traumatic was out.
Yes.
The next thing was that there had to be no Hill-Sachs lesion and no bony fracture on the glenoid or any kind of
Yes.
type 4 slap, so a real disruption of
Yes.
so you're taking out that type 1 group, okay?
Yeah.
Um, we also took out people where if you went inside with the arthroscopy, everything almost looked pristine, ball looked pristine, socket looked pristine, labrum intact, no scuffing, no little clefts, no tears,
Mm.
no disruption, but was just simply really baggy. Okay, so
Yeah.
even
Okay.
a bit baggy and a bit loose, we took those out because we were
Yeah.
worried it might be type 3 muscle
Yes.
happening type problems. So when you go in with the scope, what you had to see was some kind of very subtle cleft, a capsule just beginning to come away a little bit, but not an obvious Bankart. The
Yes.
labrum was there, but it might have had a bit of roughening or scuffing. So it looked like there was very minor uh, uh, problems within the shoulder, but nothing obviously structural. That's
Yeah,
the good.
yeah, yeah.
That's the
Okay,
good.
okay. It's really useful for me to hear you step through those things because, as you know, the healthcare system in New Zealand is funded and structured differently depending on trauma. So it's really useful just to dig into those different aspects of that so that you could know who the patients are that aren't, so even if they do have some of these pathological lesions, like you say, they all did, didn't they? But then surgery is not beneficial
Yeah.
for those
So your
people. It's not.
thrower, that
Yeah,
would include your thrower. So if somebody had what we call like a slap 1 or a 2, that
yeah,
could be that group. And
yeah,
doing a capsular shift operation in that patient doesn't appear to be any more beneficial than placebo.
yeah, yeah. It's an enormous piece of work, Anju, but it's really useful for us clinically, isn't it, to know and help us move forward in that space.
Yeah.
So congratulations and
Oh,
thank you.
I cannot begin to tell you how helpful it's been. And also because, Margie, the difference it's made to my clinic. So you've got to
Yeah,
remember that when patients used to come to me, they'd come from all over, and some were told, but I've had all the physiotherapy, I've done months of it, I just
yes,
need an operation now. Or I'm confused. One surgeon's told me I need a shift, somebody else's. And I cannot tell you how in the last 2 to 3 years, it has fundamentally changed
mm,
patients' beliefs, their buy-in. It's
yeah,
closed the door. It's helped them to move to acceptance. Honestly, it's been, if there's one thing in my whole career I am so glad I've done, and I know that I've made a fundamental change, has
yeah.
been that trial.
Yeah, that's it's a great contribution, and that's why I wanted to get you on so you could share with people. Do you know, because it is enormously important. Is there any tips for clinicians then about how you share that information with clinicians, with patients rather? How do
Yeah,
you
yeah. I
what do you
mean,
think they should say or
yeah, the great, so a lot of patients will come to us because they're desperate. I mean, they'll say, but surely there's an operation you can do to fix my shoulder, or you can fuse it, give me a shoulder replacement. The fantastic thing about this, though, is do not underestimate sometimes the intelligence of our patients.
yeah,
And you know what? A lot of them do respect evidence-based practice. So I
yes,
will in clinic say to me as well, we can reassure you now that the kind of advice we are giving you is not based on our biases or our specific opinion. We have now run this clinical
yeah,
trial, and we can categorically tell you that this operation has no benefit over placebo. We did it pretty much what I've said to you.
yes, yes,
We then talk about the fact that we also know that historically, when we were doing this surgery, there was about a 50% failure rate. So even
yeah,
if we were to offer you the operation, there is about a 50% chance at 2 years you're going to come back complaining of pain and instability again.
yeah, Yeah.
So people do respect evidence-based practice, and I think, and the other thing I would say to you is it's quite a hard case to argue against. And
Yeah.
now I would say to patients is that if you ask for an expert consensus amongst our 5 surgeons in our team, I'm afraid none of them will choose to operate based on the current evidence.
Yeah.
So
Well, yeah.
people are quite respectful of that, but it means we can move them on to acceptance.
Yeah.
Whereas before we would have carried on and we did revisions. I mean, God, in the old days with some of these hypermobile patients, we were doing a capture shift and then a revision. And, you know, it would start dropping out the front. So we tighten the front. Then it started
Yeah.
dropping out the back. Then we tighten the
Yeah.
back. I mean,
Yeah. We've moved
stuff
into a
is
different
it.
space. Yeah. Yeah. Well, it's a
Because
fantastic.
we kept thinking that it was all led from here.
Yes.
And surely if this is coming out, then the driver's got to be within the shoulder. And I've got
Yes.
to say, it's quite a lot of the drivers from outside the shoulder.
Yes. Yes. It's been fantastic catching up with you, Anju, as always. Do you have any final comments for clinicians around dealing with these complex patients or specifically in these atraumatic/MDI? What are your tips for clinicians, especially younger clinicians who these patients
Mhm.
will often present to first? What do you say to them? What should they know?
I think the key thing to say is treat the person and not the joint,
Yes.
or probably better saying is treat the person attached to the problem, not just the joint in itself. So it comes back to that whole biopsychosocial. If things are not getting better, there's going to be very obvious reasons, but I would really start thinking about the psychosocial context. You know, so we can keep this simple, all right? I could be really controversial, but I would say is the
Go on.
majority of non-traumatic shoulder conditions, from cuff problems to instability, can be very well managed, we know, through lifestyle, exercise, and modification. Does that make sense?
Yeah.
So when things are not getting better, that does not negate the fact they need surgery or they need further medical interventions. I think we have to sit there as young clinicians to kind of go, okay, well, is it really about belief? Is it about your compliance? Is it that you don't really get, have you got the time to? So think of those factors rather
Yes.
than I picked the wrong exercise, or
Yeah.
it needs an operation because the tear's too big. Okay, that's my
Yes.
first bit of advice. Um, and the other bit of advice when you get to our stage is remember you cannot fix everyone. Okay,
Yes.
medicine is not a cure for all. It, Mr. Bailey taught me it's much harder as a clinician to learn to say no
Yeah.
compared to feeling like you want to fix. And so my other word of advice early on in your career is there is no one magic fix for everything, and a
Yes.
lot of things don't always get fixed. So when you're left with chronicity and ongoing problems, be open and honest that you can't always fix it, and don't bully yourself about that. That's not
Yes.
that's
Yes.
yeah. Those are my two
Or
final.
lead patients on this
Yeah,
ongoing, years of
yeah.
physiotherapy once a week, is like at some point you're not making any gains. You
No.
need to, move to a different
And the problem
strategy.
is, Margie, as you well know, that if you try keep convincing a treatment onto someone that they're not ready for, then the sad reality is that when they finally are ready for it and they're offered it, the often I hear is, "But I've already been there." Do you know?
Yeah.
So it's the
Yeah.
right time in the right place. It's actually okay to go, do you know what? It's fine if you don't feel you're ready for this treatment. And I think the art of discharge and the art of saying no is probably the thing
Yes.
I've learned most in the last 10 years of my career.
And do you have any tips there? Well, it's difficult, isn't it? Like,
Really difficult.
how do you do that? What do you think clinicians should know about that? What can you share with them?
I think you need good peer support around you. So we with really
Yeah.
difficult cases, we do what's called a complex shoulder clinic. And how do I put this? Because I know this sounds odd, but people are more likely to sue you if you refuse to do an operation or you refuse to do
Yes.
something than actually if you do a bad operation and it goes wrong, because then they're a bit like, oh well, at least you tried, doctor. So
Yes.
I think the difficult conversations are often manageable when you have peer support around you and you have a consensus group to be able
Yes.
to do that. Um, Also develop resilience in yourself. And we talked a bit earlier, but burnout and that it is draining. So
Yeah.
I think you do need to find strategies to deal with that. And maybe, even though sometimes I feel guilty that I'm a consultant and I'm a senior clinician, but if you just saw that caseload, you would not be
Yes.
able. So don't feel bad that you sometimes do need to also.
Yes. I had a really interesting, Adele Fanning and I met a few weeks ago and talked about burnout and resilience. And we talked about strategies that I use and things that she's using. What do you use? Where are you at with there?
Apart from alcohol,
I'm not sure we should confess to that online. Anything else that might be healthier for
do you know,
our
I'm
colleagues?
to be honest with you, having a really good team around me, just the
Yeah.
ability to debrief, and I just will leave with kind of, because obviously my cases are getting complex, but we know that 30% of my cohort have significant coexisting mental health disorders.
Yeah.
The other thing that I've now done is developed mental health support for me and the patient. So we have psychiatry liaison working with
Yeah.
me. So I know it's a bit idealistic, but I think what I'm kind of saying is you need good peers, have a good team around you.
Yeah.
And yeah, and family can be that too.
Yeah.
It doesn't just have to be people at work. I mean, my daughter and my husband are quite good at listening to my debriefs. They just let it go over their head. But you don't underestimate how just doing that. So for me, that's very helpful.
Yeah.
Yeah. But
Having
a
that
team,
ability to vent that, Yeah.
I don't
Yeah,
know,
of
you
course.
must see, I mean, it'd just be interesting to see from your listeners, but how do you do that when you're in sole private practice? I
Yeah.
sometimes think that's pretty tough.
Yeah, I think so. And I think that's really tough. And probably not that helpful. It's more challenging maybe because you don't have that same peer support you talk about. Hey, it's been great, Anju. Any closing remarks? Anything you wanted to say?
I don't think so. I mean, God, I could talk to you forever.
I know. I
Felt
know.
like it just went like that. I
Yeah, I
mean,
know. Hey, well, it's been fabulous having you
but if
on.
anyone wants to read the paper, it's in the BJSM, and we've done a
Yeah.
nice infographic as well. But yeah, I think just have lots of confidence in that. If you listen to a person and you treat them as a person, I think that's more likely to get the outcomes that you want.
Yeah. Thank you very much.
Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.